Hello, everybody. Welcome to today's webinar training. All of you are in the BPCI-Advanced program, of course, as part of the Triarch Health Alliance. And as such, what Medicare requires as part of being BPCI is, or at least requests, right, what they're trying to promote is that you are now part of an advanced payment model. So historically, as a practice and kind of just being, outside of any advanced models, just normal fee-for-service from Medicare, you had to report MIPS, and you still do, right now have to report MIPS, but you are also part of BPCI, which means that it qualifies as an advanced payment model under the quality payment program. So you're kind of straddling both worlds right now. And now that may change in the future, which we'll talk about that for next year and another time. But right now in 2018, you're straddling both worlds. And so as such, you need to report a couple of additional quality measures as part of being an APM, which will give you the maximum savings. So if there's savings on an episode, which of course is, one of the goals here, right? You will maximize that savings by reporting these quality measures. There will be a financial hit if you don't report the quality measures, meaning you won't get as much back even if you saved it. There'll be a penalty. So you can think of it as a bonus or you can think of it as a penalty. We like to think of it as, maximizing the amount of the savings that Medicare will give you. They're giving you a bump if you report these. And Julie's going to make it really easy to understand. They're not really that difficult. I mean, there's a little bit of hoops to jump through, but they're not super difficult. It's not like, doing MIPS, which you've had to do, which is a much bigger ordeal. So, you're probably already doing these things or at least on your way there. And so we just need to cross some T's and dot some I's and report them a certain way. And then that's what Julie's going to talk about here. So without further ado, I will turn it over to Julie. We're going to send you this PowerPoint, so you will have this for your records. We are recording this as we noted, and so you will also be able to listen to this in the future or, let somebody else in your practice listen to it. And in the interest of everyone's time, we're going to cover off questions kind of individually. So we think that's better because there's going to be any questions you have are probably going to be pretty specific to your practice and your workflows and how you do things. So Julie will be available for follow-up questions offline and to work through those details with you as you have questions. All right, Julie, take it away.
Okay, thanks, Sabrina, and thanks everybody for joining us. We're going to try and make this as not scary as possible. So Sabrina touched on this, but I like to reiterate, why is it that they want us to report quality measures? So much of the conversation about BPCI-Advanced has been about, beating a target price and saving money. And, we want to make sure that this is not just about cost, right? This is also, we can't be cutting cost at the detriment of the patient, right? We can't compromise the care that the patient is being given. And one of the ways that we make sure we haven't done that is by tying that payout to quality measures. So, and you'll see when you see the list of quality measures themselves, you'll see how CMS has used that to ensure that we are doing our best to hit that sweet spot of reducing cost, but also increasing quality. So that's why quality is important. So what are those quality measures? There are 7. It sounds scary. We're going to make it less scary. 2 of those quality measures are required for every clinical episode. So the all-cause hospital readmission measure and the advanced care plan measure. Everybody who's participating in BPCI-Advanced has to report those 2 measures. Then there's 5 additional measures. Only 3 of those apply to the clinical episodes that our world is reporting. So of those 5, the 3 that we're going to worry about are the perioperative care. So that's the putting that patient on the first or second generation cephalosporin prior to surgery. If you're in the bundle for hip and knee, which most folks are, then there's the hospital level risk standardized complication rate following elective primary total hip arthroplasty and or total knee arthroplasty. And then the last one is AHRQ, patient safety indicators. So before we get too worried, wait until I get to the next screen where it gets really good. This is just kind of a different representation of that same data. So this is straight out of the CMS website for BPCI-Advanced. It shows each of those quality measures. It helps us understand which of the DRGs or which of the clinical episodes the quality measure applies to. There's a reason I have two of these circled in red, the advanced care plan and the prophylactic antibiotic. Those are the only two we actually have to report something on. The rest of these all come straight off of your claims. You don't do anything. So in other words, if the patient is readmitted, right, that's a bad outcome, right? We don't want that to happen. We got to take good care of these people so we don't readmit them. If the patient is readmitted, they know the patient is readmitted because they get a claim from the hospital. That's an example of we're not as the surgeons, billing folks and clinical.
Julie?
Yes.
Sorry, I'm going to interrupt for just a second. Your audio to me is a little bit patchy at times, not all the time, but a little bit patchy.
Okay.
I don't know if anybody else is experiencing that, but if you could, I don't know if there's a microphone or something else that you need to.
I apologize. Give me 1 second, and I'm going to go find a headset.
Yes, this is Michigan Orthopedic, and we're noticing it as well.
Okay.
Hold the phone, guys.
Okay.
All right, guys, hang on. I'm going to switch to my phone. Give me 1 second.
All right, can you guys hear me now? Is this any better?
Yes, so far so good, and you were really fine most of the time. It would just at times it would kind of fade out a little bit, and we didn't want that happening when you were saying something.
No,
super especially important. All right, so far so good.
All right, thanks you guys. Sorry about that little glitch. So in looking at this, and I have one more slide that's just really going to beat this in this concept into all of us, is really what we have to worry about are two measures. So on this next slide, this is now kind of the summary of what I've just been spitting out over the last 3 slides. There are 3 inpatient quality reporting measures that will be calculated from administrative claims. So they list out those 3 measures. In other words, no action required from us for those 3. The 2 that we have to worry about, now here's the detail. So that perioperative care, selection of the prophylactic antibiotic, very specifically first or second generation cephalosporin, and that's NQF number 0268. That is, you can either submit via QCDR or via G-code on your claim. And here are the 2 G-codes. If any of you out there have historically done PQRS, back in the day before it got mushed into MIPS, I know this is a measure that I reported for some of my practices who were surgeons. This was, you know, back in 2014 and 2015. This was a measure that we were reporting because it was relatively simple to report. I think even back in those days, the list of antibiotics was a little broader. They've narrowed it down. So these are the two CPT codes, G9197, which indicates that it was given, or the order was given. And then G9196, you actually still get credit for meeting the measure, but it's that you've documented somewhere the medical reasons for not ordering. And this hyperlink at the bottom, we can actually send you, if you would like to review the entire quality measure, we can send you the nitty-gritty details. But for example, obviously if they're allergic to Keflex, you're not going to put them on this. So in any event, these are the codes you would want to have on your surgical claim. For the advanced care plan, we're going to talk more in detail about both of these measures, but advanced care plan, that is that's something that can happen anywhere. This is not necessarily, or really isn't tied to the surgical event itself. So I think of this as something that's being done in an office visit prior to the surgery. It can even be reported on a claim where you're billing hospital rounds. So, but I think most folks think of this as something that's happening prior to surgery. It's possible the patient has an advanced care plan on file with their PCP or at the hospital. So what you're doing is you're documenting with these CPT2 codes, 1123F and 1124F, you're documenting that the advanced care plan was discussed and documented, not necessarily that you were the one who did that work. So keep that in mind, that this is not necessarily something you have to do yourself. You're just documenting that there is an advanced care plan on file for the patient. That being said, let's go to, okay, so in further detail about the first measure, the prophylactic antibiotic therapy, right, we're saying that the doc had an order on file. He placed the order prior to surgery. And then I've got a couple screenshots here of what the op note looks like. Your guys are already doing this. They may not be specific enough, like that top example, it just says preoperative antibiotics were administered. In my perfect world, he'd get specific here and say that it was the first or second generation cephalosporin, whatever it is he's giving. The second example, there's somebody out there who's prescribing vancomycin, which, you know, great antibiotic, but it wouldn't actually meet this measure because it doesn't fall into that classification of medication. So change required, yes, of the docs. Let's make sure they're educated about this. I'm sure this is not the first they've ever heard about it. So we want to make sure that our documentation supports anything we might be placing on our claims. And then here's an example of what the claim would look like. Billing out my 27130 for that hip, and including the G9197 to indicate that we did in fact have an order for that antibiotic. And then there's just some details that I've got here in a little box about the numerator and et cetera. This is something you guys can review later. So that is the prophylactic antibiotic therapy measure. For advanced care planning, again, keeping in mind, the idea here is that the documentation, you know, when you report this measure, 1123, are all sitting there going, okay, fantastic, what happened? If I ask the question and the patient says, well, gee, no, I don't think I do have an advanced care plan on file. It's a service that you can actually provide. It's a billable service. So just throwing that out there. I know you guys are all super busy and nobody's got an extra 30 days in their life to sit and consult with the patient. But if you do, and you want to, you do want to go down this road, I actually have advanced care plan templates from each of the states, Michigan, Florida, and Texas. So if anybody's interested, let me know. I'd be happy to share that with you. So to sort of make it, something that's operational. It's just a lot of, who would be the person you would designate to make decisions for you. So you can get paid for that service if you choose to do it. So if you're going to actually sit down and have the discussion and do the documentation and create the advanced directive, you would want to go ahead and bill that $99497 and earn that $86. But this is
and Julie meant that it takes 30 minutes, not 30 days. Yeah. But I think
did I say 30
minutes? 30 minutes. Yeah, it probably feels like
30 minutes. No. So,
but yeah, not that anybody has any extra 30 minutes either.
Yeah, everybody's so busy. But if you, hey, if you're going to do the work, be sure you bill for it and get paid for it. Even if you do bill the $99497, you're going to want to go ahead and submit the 1123F that indicates the care plan was done. So the quality, you won't get credit for doesn't make any sense to me. It seems like they ought to be able to figure out from this CPT code that you should get credit for the quality measure as well, but they don't work that way. So you'd still have to submit the 1123F. So that's the advanced care planning. So just to reiterate what Sabrina was saying at the beginning of the call, why is this important, right? They're tying the positive or negative total reconciliation amount will be adjusted based on this quality performance score. So that's what that's all about. Okay, so that was quality, 2 quality measures. Now there are these improvement activities. Everybody who reported NIPS last year has been down this road of improvement activities. So why the improvement activities? This is tied to the fact that the BPCI-Advanced model is an advanced alternative payment model. And as such, you are required to report a minimum of 4 MIPS improvement activities. For those of you out there who did MIPS last year, you probably reported at least 1, maybe 2, and probably just that many. Although I spoke with some folks here in Detroit who did 4 or more last year. So I want to make sure everybody understands that this is not what we're going to talk about right now is no different than that. It's the same pile of improvement activities. There's nothing new or different that you have to do, just more of them. If you only did 1 or 2 last year, you've got to do 4. So let's talk about that. I went out to the QPP website and, navigated to the improvement activity section, and I looked through the list and I clicked on a bunch that looked like things that I think practices probably are already doing. They just aren't reporting that they're doing them. So this is just an example of some of those, and I'm going to dive into about 5 or 6 that I think are a great fit for your practices. I just want to bring attention to them and suggest to you that, it's very likely you're already doing these things. Go ahead and get credit for doing them, and you have really nothing extra to do other than maybe write a policy and a procedure that says, yep, we do this. So let's zoom in. Well, first, I'll look at a couple of these, and then we'll go into the detail. A lot of us are already engaged in the PDMP, the Prescription Drug Monitoring Program here in Michigan, right? It's MAPS. Your docs may already be, dialing into MAPS to report that they prescribed an opiate, right? That's an improvement activity. Give yourself credit for that. Maybe you are already doing fall screening and risk assessments. Maybe you, and I'm going to dive into the details on some of these other ones. I know last year for our folks, most of us reported the Provide 24/7 access. That was one that was just such a natural for anybody using an EMR that also has a patient portal, right, which is required if you're going to get credit for meaningful use and for MIPS. So let's jump to the detail slides so they're easier to read. So this is that one we were just talking about, providing 24/7 access, right? And then they give you the details, right? Expanded hours, evenings and weekends with access to the patient medical records, use of alternatives to increase access to care team by MIPS eligible clinicians and groups, such as e-visits, phone visits, group visits, visits in alternate locations, provision of same day or next day access. And so these are things you probably already do. And so let's go ahead and get credit for that. And so when you know, anybody who's attested for MIPS knows what this was like, but literally you're signed into the website and you click the button that says, yep, I did this. It's simply attestation, which is saying, yes, I am doing this. Now, you could do that for any measure, but you know, the devil is always in the details, right? What if you get audited? What would you need to be able to provide in support of the measures you attested to participating in? So that this suggested documentation section at the bottom is the suggestion of, well, if I got audited, what would I have to produce that proves that I did this measure that I said I did? So for most of them, it's a policy and procedure, very simple, P&P. For the one of the practices I work with, I logged in and I took some screenshots of, you know, the portal communication tab that shows, yep, we're communicating with patients using our portal. And, oh, here's our calendar for the Saturday hours when we saw some patients. And so just, you know, anything that you can think of in your EMR that would demonstrate that you are actually providing this, this access to your patients. So that's one measure. Implementation of use of specialist reports back to referring clinician. Well, who doesn't send that thank you letter back to the guy who referred the patient to you? I think every orthopedic practice does that. Give yourself credit for it. You know, and in your you know, little audit folder, you would keep a copy of one of those letters back to the PCP or the referring provider, and you know, maybe a little blurb about, yep, we're generating these out of our EMR, and you know, a little policy maybe that states, yep, it is our policy to always send a thank you note with a copy of our findings back to the referring provider. So something you're already doing. This is a twofer. This improvement activity, there's two here. And keep track of this data. So, and have documentation so that supports that this is being done. And if you're, you know, using your EMR to do it, maybe a couple of screenshots. So if my friends in Texas are out there, this is something that we do, and it'd be a couple of different screenshots of the tool that we're using, and, you know, how we're tracking that order in the system, and piece of cake, we can document that we are actually involved in this improvement activity. So there's 4. Here's the 5th. Care transition documentation practice improvement. So this is something that we are doing in conjunction with you regarding the management of the care transitions through the entire 90-day episode. So, you know, this is something that we are doing. You guys are documenting the discharge plans and sharing those with us, and we're getting the patients logged into the new One Team Care platform, and we are managing that patient throughout the entire 90-day episode of care. So that definitely falls into this category. If you were to go out and look through the different improvement activities, I think there's 118 of them. There are a tremendous number that are tied back to care coordination, which are also very applicable to what we're doing with the model. So I don't want you to be afraid of this requirement to report 5 improvement activities. I'm certain you're already doing them. It's just a matter of, you know, documenting a quick little policy and procedure so that you can attest, you can, you know, prove that upon audit if it should ever happen. So to summarize what we've just talked about, that's really as hard as it's all going to be. 2 quality measures for improvement activities. Keep in mind those quality measures could be what you did in PQRS days for MIPS quality. You want to make sure that those CPT2 codes are active in your EMR or PM system. So, right, you may not have the entire CPT code listing. You might not have every HCPCS code in the whole entire world in your system because you don't have a use for them. So that might be the first thing to check, that you've got the G9197, G9196, and 1123 and 1124F. Make sure those are available to you. Implement a plan to document the care tied to the measure, right? We can't just send those codes. We have to actually, document that, we did give that order for the antibiotic, and we did, establish that the patient has an advanced care plan on file. And then, with those improvement activities, I say just go get credit for stuff you're already doing. I'm pretty certain that's what's going to end up happening. And then write a policy and procedure. And we're here to help. If any of this is overwhelming to you and you'd like some hand holding, that's what we do. That's what we're here for. And I certainly hope that you would reach out. So Sabrina, I hope that wasn't too fast. But that is really everything I had to share with the group today.
Great. Excellent. No, I think that was good. It was a good, thorough overview. You're going to get the PowerPoints and the recording, of course, everyone. And as Julie said, if you have any specific questions or we can help you with any of these and how to implement them, Julie is an expert in this, so she can certainly help you. Thank you for joining, and we will keep working with you. Appreciate all the engagement and all the good work that everyone's doing, and look forward to next steps. So let us know if you need anything. Thanks, everybody. Bye-bye.
Thanks, Sabrina.